phenylephrine is a drug that we use most of the time. Practicality and scientific knowledge tells us that it is not as useful as we think it could be. What about dextromethorphan? We know that it is a centrally acting antitussive and therefore not recommended below 4 years of age. Within 4 to 6 years, you have to use it with caution. The dose is this 7.5 milligram orally once every 8 hours in children below between 4 to 6 years. Life-threatening side effects following misuse and overdose. Please remember this last line, that this life-threatening side effects have almost always followed misuse and overdose. What about ambroxol? Ambroxol is a drug that was not very popular in the West. The US FDA has still not approved it for use in their country, but this is very easily available in most other countries, and that speaks a lot. Recommended above 1 year of age only in wet cough, and that too as an adjuvant. Children with wet cough are not many in day-to-day clinical practice. The dose is 7.5 milligram once or twice a day based on body weight in toddlers. Above 6 years, it is 15 milligram twice daily. And this is one drug that is used extensively by practitioners. What about guaifenesin and its role in cough syrups? It's an expectorant, limited data on effect on colds and coughs. It's recommended above 4 years of age in this dose and not exceeding 600 milligrams per day. Above 6 years, it is 100 to 200, double the 4 to 6 years dose, and the maximum dose is 1.2 milligram per day. This is a new entrant, and I'm sure a few questions would be asked on this. In contrast to guaifenesin, which is a centrally acting antitussive, this new entrant is a peripherally acting non-opioid antitussive. It is useful in non-productive cough as compared to dextromethorphan, which is a centrally acting antitussive and hence lesser side effects. These are the drug doses. This is a new drug that has come into the market, and very few of us would have used it to know its effectivity. The only advantage is that it is peripherally acting and therefore could have less side effects as compared to the usually used dextromethorphan. There are very few conditions in practice where we would want to suppress cough, because we all know that cough is a protective mechanism, and therefore when it comes in the way of the child's sleep or the child's activity, or when it is distressing like a pertussoid cough, only in these situations these cough suppressants have a role, and that too for a short period of time. Now the next question that all of us have to answer and know is what is called by GMP. GMP means good manufacturing practices, and this has been alluded to by Professor Shivananda in his introductory remarks, and there have been WHO recommendations. Now put good manufacturing practices in perspective. If I am driving my vehicle and if there is a red signal, I stop my vehicle, and when there is a green signal, I move my vehicle, the chances that I will have an accident is minimized. And the same way, if the manufacturing companies follow the good manufacturing practices, it is very unlikely that incidents like this that has happened in Madhya Pradesh, Rajasthan, and Tamil Nadu could have been averted. And what is more important than the circular issued by the government of Karnataka dated 6/10/25, which clearly says do not use cough and cold syrups in children below 2 years of age. Between 2 years, use with caution, and in older children only after thorough clinical exam of the lowest effective dose for the shortest duration. This is something that every practicing clinician has to remember and not to prescribe it for 7 days or 10 days without assessing the response to the medication. And here are the title about the good manufacturing practices. What does that transform to us as practicing pediatricians? When we prescribe drugs, it is worthwhile to prescribe drugs which belong to reputed companies who have time tested their products with good manufacturing practices. I still remember the syrup of fexofenadine from a company was withdrawn from the market because they found some flaws. And this syrup was not available for more than 1 year and it has reappeared in the market, which means the company itself has a good manufacturing practice. And we need to select such companies when we prescribe medications, and the responsibility is on us. Now, let us look at this diluent which has been spoken too much of in the past 2 days, including our national president elect yesterday on the TV media. Propyl glycol. The cost of a liter of propyl glycol in the market is around 140 rupees. This is an excellent solvent which is used in the preparation of not only cough syrups but quite a few other medications and is usually safe. It is designated for medical use and it is more expensive as compared to ethylene glycol or the diethylene glycol, which is the focus of discussion. Now, let us look at what happened in All India Institute of Medical Science, thanks to Professor Kabra, who shared this article with me. 11 children were admitted in All India Institute of Medical Science in 1998 with acute renal failure. And when they were investigated, they were found to have diethylene glycol poisoning. The media hype was so much that they could not publish this data until the year 2007, and then they published this data. This diethylene glycol was the diluent found in paracetamol syrup. 9 out of the 11 children died. The remaining 2 who survived had CNS sequelae. So it's not that only cough syrups could matter, even paracetamol has been implicated. Now let us look at what this diethylene glycol or ethylene glycol is. It is a popular industrial diluent. In common practice, this is used for refrigerator cooling in the refrigerators that we use at home. Why do pharma people use this particular compound? Because it is cheap, it is easily available, it has a sweet taste. The toxic dose of this product is 1 milligram per kg of the 40% solution. It can cause nephrotoxicity and neurotoxicity. And please remember that these children who died of nephrotoxicity and not due to the common side effects of the common drugs that we use in the cough syrups. Now, contaminant of paracetamol from Haryana, I showed you the report. Then Dr. Kasi shared this information with me that in Mumbai, when they were the last year postgraduate students, IV mannitol was contaminated with DEG and they investigated it in the year 1979. And presently, Rajasthan, Tamil Nadu, and Madhya Pradesh, all of us have read about it. And let me make you remember that in Tamil Nadu, there was a clear evidence to say that the percentage of diethylene glycol in the syrups that they investigated was much higher than the maximum standards that could have been there. Now, the question is, what is it that the society and the state can do? Meticulous checkings of the batches by the members of the Drug Controller General of India or the state before releasing them into the market. Now, ethical considerations also matter, but I do not know to what extent it will be influential in the sense the person manufacturing a medicine, particularly syrups, should value life of a child more than the fast buck he can make by substituting propylene glycol with diethylene glycol. But I think it is an utopian dream at this point in time unless there are stringent, strict administrative measures. Now, what can we as pediatricians do? We can look at safe and proven methods of treatment like cold mist humidifiers, which can help ease nasal congestion by clearing the passages. We all use saline nasal drops or spray. We can use them to keep the nasal passages devoid of stuffiness. Bulb syringe, which is cheap, can be prescribed for every infant for suctioning mucus from the nasal passages, and the mother guided and helped to do so. Encourage hydration. I always remember Professor Shivananda used to tell 2 spoons of boiled lukewarm water once every 1 to 2 hours dilutes the phlegm and also gives the mother something to do because she has to get engaged in the child's care. And this hydration is something that is advocated. Fever reducing medications like the safe acetaminophen in the dose prescribed or ibuprofen can make the child much more comfortable when the child has fever due to a febrile illness. Honey is one medication that has been advocated in children below above 1 year of age because of the fear of botulism in children below 1 year. Honey is supposed to be a reasonable, safe medication to be advocated as an adjuvant with the other medications. The bottom line that you and me have to remember is to give our time and counsel effectively. And that can be done at this point in time because every parent who walks into the clinic asks us about this controversy, and the time is now ripe to share with parents that these are the recommendations, and that is why we are prescribing. Now, for me, you, and all those listening to this webinar, there are some points to ponder. The doctor who was arrested in Madhya Pradesh may be asking this question to himself, and all of us as pediatricians will ask the question to ourselves. But I don't know where the answer lies. The question is, if combination drugs syrups are irrational, why are they still in the market? They should have been off the shelves of the market long ago, like what has happened in countries abroad where this is strictly followed. Now, a pediatrician only does not prescribe the medicine. A good number of sales occurs across the counter, particularly by the pharmacist in many places. We all know that. Can somebody regulate the sale of these medicines without prescription across the counter all over the country? And that is something that we need to answer. Used with discretion and dose properly calculated, not only for the weight but also for the age, for the minimum periods, can reduce the side effects to great extent of most drugs that have been used. That has been the experience of every one of us. Misuse and overuse by parents and caregivers, either because of misinformation or to cure their child faster, are points that we need to consider on which the doctor does not have any control upon. I would like to share with you the Cold Act Baby episode, which haunted me about 15 years ago. I treated an infant or a toddler, and the infant was brought drowsy. The infant was prescribed 0.5 milligram ml of this Coldac drops 2 times a day. I could not find any reason as to why this toddler was drowsy. We admitted him in the hospital, started him on IV fluids. This infant was suckling well at the mother's breast, but this infant was drowsy. I was planning to do a lumbar puncture, but could not find evidence of meningitis, so I did not do a lumbar puncture. On the second day, the grandmother was there in the ward. The mother had gone home. The grandmother asked me a question. Doctor, that small bottle that you had prescribed, for how many days was it? I said 7 days. She said, my daughter-in-law completed that bottle in one dose. I was telling her the doctor would have prescribed less, but she gave 5 ml instead of zero point 0.5 ml. And in 2 days, this baby recovered. So these are the common mistakes and fallacies that would happen every now and then. There have been studies which tell us that 30 to 35% of our patients understand the counseling that we do when we prescribe medications. Some people need it the second time, some people may need it for the third time because they may not focus on what is being told. You and me remember and also accept that within hours of going home, the same mother calls us and tells us, Doctor, can you please repeat the way I should give this medication, which is commonplace. And that is the extent to which parents focus on the drug and the dose in day-to-day clinical practice. Now, what can I do or what can all of us do from tomorrow? And we have been doing this from the last 1 week. I am trying to unlearn my usual prescribing methods and relearn. Meaning, depending on the age of the child, depending on the symptoms, which are the drugs that are permitted for me to prescribe. Prescribe based on age and per kg body weight for the minimum duration possible. We have to in future look out for single molecule preparations like only antihistamine, only bronchodilator, only cough suppressant when needed. At this point in time, there are not many pharma companies which have these single medications except a few. Make sure that you advise them to frequently revisit to make sure that the child has been improving over time. You may not charge them for the second consultation, but only to make sure that the child is improving. The last but not the least point, spend more time with parents to educate them about the newer recommendations. I have today showed the government of Karnataka circular to parents to say that this is what it is and that is why we are giving you these medications on not many medications. Now, public inquisitiveness, as we discussed, is at its premium now with media hype and propaganda. We have to utilize this opportunity to educate parents about the overuse of these medications as they are now faithful to listen to us. The iron is now red hot. We have to strike it. Self-audit is something that we all have to do at least once a week in order to look at our prescriptions to say how rational they were and how best we could change our prescription to be more rational on a everyday basis, because I can always look at my back because I know what I have prescribed. The only requisition is I should be willing to do that on a regular basis. That helps. I remember when I started my practice, I used to have a 200-page book where I would write down the medication errors and all other issues and read them once a week so that I could remember where things went wrong. Spend time to explain and repeat the dosage to parents so they can understand clearly. Do not prescribe teaspoons or tablespoons. It's worthwhile to go for the medicinal containers. And please tell them if you use this medication properly, this bottle is likely to get completely over by in how many days. And do not reuse this medication without medical consultation again. Now, there are a few key opinion leaders in every area. Who are key opinion leaders? They are the leaders who have been well respected in a particular area, and the other prescribers in that area look at the prescriptions of the key opinion leaders in that area, and they follow their prescriptions very blindly. So, if you are a key opinion leader in your area, if you make one mistake or blunder in your prescription, 100 more blunders will be done by people who very keenly follow you, and the mistakes multiply. So, all of us should consider that we are key opinion leaders in our area and audit our prescriptions before we hand it over to the parent or to the grandparents. Now, this is a famous saying, the KAP of practice. Knowledge can be acquired with relative ease, and all of us have been good experiencers of that, particularly before our MBBS or MD exams. You can acquire knowledge without much difficulty. Attitudes can change with some difficulty because attitude is something that is inborn. So to change your attitude is not very easy, but practice is the most difficult to change. Meaning, I have been prescribing these medicines for such a long time. Nothing has happened to anyone. Why should I change it now? Is the way in which many of us think, and therefore we not only have to acquire knowledge but change our attitude, but we should change our practice from tomorrow morning with our first prescription. And our postgraduate students, our junior doctors also follow what we prescribe, and therefore it is pretty important that we change our practice for the better and, if possible, for the best from tomorrow. Further reading for those of us who are interested, this is an excellent article, freely downloadable from the Chest Journal, which was published in the year 2014, a good article for every one of us to read. Antihistaminic use in children, an excellent article providing the basis of physiology, pharmacology, and clinical therapeutics of rational antihistamine use, and an excellent article by our own Joseph L. Matthew in Indian Pediatrics on cough syrups. Do they work in acute cough? This is something that is a 3-page worthwhile article, evidence-based, and use of antitussive medicines in acute cough, which was published in the year 2021. So these could make good reading material to every one of us. Now, I will be failing in my duty if I do not thank these gentlemen. Professor Sushil Kabra, whom I always look forward to discuss, who immediately shared that article and who also shared his wisdom with me. My own guru, Professor S.D. Subbarao, with whom I always discuss difficult cases, Dr. S. Balasubramaniam from Chennai, and my own friend and an excellent friend of mine from Raichur, Dr. Malesh Gowda, who has an excellent insight into what is happening at the ground level, at the district and taluka level. And lastly, thanks to IAP BPS, the office bearers, and thanks to every one of you for joining us at this time in order to learn and to share. With those few words, thank you.
Thank you, sir, for that wonderful presentation. It was not only science, it was arts as well as some philosophy to younger people. to follow. That was a wonderful presentation, sir. I'll just, there are few questions in the chat box. Role of glycerol, I think you have covered, sir.
Yes.
Dr. KP is asking. One more question is by Dr. Sheetal Shetty. Please comment on use and safety of butamirate for cough.
No, I would request Professor Shivananda to answer, and I will add on, because I have no personal experience with this particular medication.
Sir,
Sir?
Shivananda sir? Sir is there, but he's muted.
I think we can take the next question. Let us take it in the end.
No,
Yes,
I will
sir.
just discuss all these issues when I'm more little bit detail about the coughs, the regularly which are the coughs which are using. I
Right.
want to comment upon the regular prescriptions which are we are prescribing every day practice, most of us. Usually some of us shall I go with that or shall I wait for some time?
Sir, we will answer the questions and then you can take over, sir. If
No, that's what I'll come to that question later also. That includes that.
Right, sir. Your choice, sir.
Sunil, go ahead.
Yes, sir. Yes, madam. What to give, Dr. KP's again question is, what to give pertussis infant aged 3 months for cough?
The simple answer could be this way. One is the only medication that is permitted to give a 3-month-old is only a bronchodilator. You can't give an antihistamine. You will have to use the saline nasal drops and give a bronchodilator based on the age of the infant. And also keep a watch on the tachycardia, because the overuse can cause tachycardia in these children. The only other thing that I would ask is to, if the cough is very severe and troublesome, whether anybody else in the family had cough, because pertussoid cough is something that is not very uncommon. Even if this child had an eye infection as a newborn, chlamydial infections can cause severe cough in infants. So I would go back to the history to find out if this baby had a eye discharge. Apart from these two things, it's worthwhile looking at the environment, because somebody else in the family would have had a cough, the mother would have had cough or cold, and the baby would have got it from the mother. So this is something that we need to keep in mind, and make sure that you have immunized the child appropriate for age.
Dr.
Now,
Kishore.
one more point to be added here is, usually the pertussis in younger children, cough is not a problem. Most of them they're present with apneic spells.
Correct.
The cough, they go to apneic spell rather than having a prolonged cough. If at all the child has a prolonged cough, even though the breastfeeding is exclusive breastfeeding recommended, in order to see, usually they'll have a thick tenacious sputum that the child struggles to bring it out. In order to facilitate that, rather than giving any steam inhalation, we resort in that type of give a sips of plain water, along with especially the medicine which has antibiotic which acts against the pertussis. So usually that reduces by giving a sips of plain hot water. That will be more than sufficient.
Dr. Kishore Boindur sir wants to know role of bronchodilators in bronchospastic cough in infants.
Sir, the minimal age from where we could use bronchodilators is now above 6 weeks. The recommended way to give it is through a inhaled route, and we all know how difficult it is to give inhaled medications to infants. So if you can give the medication without the infant crying, which is next to impossible, that would be the best, or a carefully calculated bronchodilator drops that are available in the market. To the best of my knowledge, ambroxol is being used, but it is not found to, it is safe. There is no side effect. But to what extent it can contribute to recovery is something that needs to be answered.
Kishore sir, you want to speak, sir? You have raised your hand.
Yeah.
Thank you,
I
sir.
just would like to make a few comments. Thank you, sir, Professor Shivanand, for that elaborate introduction. And really, I go back to my days of my post-graduation in the 80s, when even now it is ringing in my ears. The best expectorant, he told us all, was plain water, H2O. Now and then you give a little water to the baby, and what Dr. Nagabhushana reiterated in his talk today. So a simple thing like good sips of water itself reduces the tenacity of the mucus and probably bring down the cough. That apart, all what is said today, well, it is easier said than done. Let us be very practical about the whole issue. Have you seen, see, you don't see your children too much coughing because you are not at home at that age when your child is young. But being grandfathers now, quite a lot of us in this thing, we have seen our grandchildren, we have seen our patients who cough so much at 2 months, 3 months. It is terrible to see them cough in which comes in spasms, and the mother or the whole of the family is there for us to do something for this particular child. And just telling them that, yes, saline is there, give some water, don't give this and things. But they are expecting a huge thing from you because they have come for some relief. As Nagbhushan said, don't give this below 6 months. So nothing can be used below 6 months. It is really very, very difficult in practical these things. I'm sure it, what is to be done is something which is really, nothing is written anywhere. But then, yes, we do take risks sometimes, and we'll end up with problems like Dr. Praveen Soni today. Yes, that risk is always there, but we have a dichotomy of practice versus the policies. What has happened? As Dr. Nagbhushan brought about, these drugs are available over the counter today. You go to the medical shop, and I keep telling my patients that even if you give the money, the pharmacist is ready to sell his mother and father also. Any drug you want, be it a rat poison also, is going to give over the counter. This is what is happening in a country like, I do not know when our country would, get back to regular practice, ethics, etc. I wouldn't want to keep you all waiting for too long, but well, it is really difficult to convince a parent of a child who is coughing so much to tell them that there is no medication available, wait for the cough to subside. It is next to impossible. I'm sure they will shop for 2 or 3 pediatricians or doctors, and one of them is going to write, or they are going to go to the counter and get their medication. Thank you for the time allotted.
Thank you, sir. Dr. Sagar Rati would like to know about Ayurvedic cough syrup, sir.
Sir, Ayurvedic cough syrups are there in the market, quite a few of them. But professionally, I don't think we are capable or responsible or knowledgeable to speak about them. What I do in my practice is tell them that you can take a call. I am not an expert on Ayurvedic medication. What I can tell them is the innocuous tulsi that is there, boil it well and give the concoction, because once you boil, nothing, the no bacteria or virus remains, or honey. These are things that we can tell. But to prescribe an Ayurvedic medicine, we are not the right people. If parents want to use it, it is their choice.
Okay, sir. Dr. Anjana Patil want to know Kurki syrup. Oh, what about the use like, sir?
Sir, I have not used
CUI
it,
syrup.
so I don't know.
Okay, sir.
Kurki syrup is only made out of turmeric. I don't know whether how far that can be used by us, because you don't know anything about. Even though Ayurvedic people, the medicine encourages to use the that what is it, the turmeric in the cough. We don't have a, but as a home management of the cough in the home. Many mothers, they telling that they are giving a cough or there is hot water with turmeric powder. We don't have an experience of this Kirki because we can't prescribe as a allopathy doctors because that is belongs to the turmeric. We don't know much about it because even though the benefits of turmeric we know, but as it is, we can't prescribe with that.
Okay, sir. Dr. Jalil Ahmad want to know, can we have a marker on every cough syrup bottle about the solvent? Insist on label reading.
Sir, that's a very valid point, but unfortunately, either me, you, or IAP cannot implement it. It's a policy from the government which has to do it. We can only send our recommendations to the DCGI or to the government of India through IAP, but the policy makers have to take that decision. We can't.
Yes, sir. Dr. Shashidhar Nanjappa want to know, government recommendations to use only inhalers in less than 2 years. Practically, is it possible?
It is difficult, sir, because see, it is a different thing to make a policy. I would put it this way: my wife cooks well. I know the science of cooking, so scientifically I am correct, but I can't cook. So making a policy is a different issue, but what happens at the ground level is another issue. And we know in medicine, two children don't behave in the same way because it is the body that metabolizes the medicine. And to add to it, you have the beliefs, you have the caste, and you have the attitudes of the parents that determines the treatment. If the parents do not want the inhaled medicine, that's the end of the story. So all these factors contribute for the use of inhaled medications in toddlers and infants. And that is the most difficult age group to give inhaled medications.
Thank you, sir.
No, right now, most of the people, they are using this nebulizer for all this top of cough.
Correct.
They are using left and right.
Correct.
Whether the child has a simple cough, whether the child is having a wheezing cough, whether the child, whatever be the cough they are using, especially nebulizer with the bronchodilators.
Yes.
And to be frank, at most of the houses which nowadays, you can say alternative or 1 and 3 houses, they have got bronchodilators, especially the they have got that mask which they are supposed to give this nebulization, especially nebulizers also.
Correct.
So that being that, whether you like it or not, people are using already, but they're not giving inhalers. They are using the nebulizers, and we don't have a guidelines to use nebulizers. Even though we say that it's abused or misused, or you can say overused, people are already using it, and many people they are using themselves at home.
Yes, sir. Dr. Anjana want to know any role of steroids in post-viral coughs.
So the post-viral coughs generally subside by about 2 weeks, sometimes 3 weeks. It also depends on two issues. One is the season of the cough and the virus that has caused the cough. We all know that post-adenoviral coughs are very difficult to treat. Vis-a-vis if it is an echovirus or other milder virus, these coughs do subside faster. There are no recommendations to use inhaled corticosteroids, but maybe 1 milligram twice daily for about 3 to 5 days is something that can be tried, but this is not the usual recommendation. The difficulty in using such high dose in children is that if you are not careful, the steroids can get into the eye, and if you are not using a properly used mask. So I would be very wary to use inhaled corticosteroids to reduce the intensity of cough in infants and toddlers.
Yes, sir. I think next question has been already answered. Role of Ayurvedic cough syrups like Honitus, Adulsa. Dr. Jalil Ahmad, the point to mention about care module of IAP Action Plan 2025. Dr. Anjana Patil again want to know what about normal saline nebulization in dry cough, sir?
Now, there are three types of salines that people are using. One is the 0.9% saline, the other is 3% saline, the other one is 5 or 7% saline. Our experience has been with 0.9% saline and 3% saline. This 3% saline came into vogue when we had children with bronchiolitis, and where it was said that it would break the thick mucus, uh, the mucus content of the secretions, and that is where it has been used. Both 0.9% and 3% are safe, and they can be tried. They do not have significant side effects.
Okay.
It has been found that especially there are some studies where they have compared the use of 3% saline and especially in the usefulness of that in bronchiolitis. What has been observed was some of the children who have been given this 3% saline nebulization found to have increased risk of bronchospasm. So they were, especially they differ to use this 3% saline as nebulization in treatment of cough, because sometimes it induces hypersecretions that may cause more of a the bronchospasm, and that's why the people are little bit careful in using that 3% nebulization in all the types of cough syrups, all these types of coughs, especially wild coughs. Even though some people prefer to use this in a dry hacking cough, they are found to be useful. But in case of other types of cough, you have to be careful in using 3% saline nebulization because it may induce bronchospasm.
Next question is from Dr. Girish Hadley. Can we use nebulization in kids below 2 years when syrups are not allowed in bronchiolitis and wheeze?
Now, I would just tell a few points and then I will hand over to Professor Shivananda. The sheet anchor of treatment of bronchiolitis, particularly inpatient, is oxygen. That's a statement which is true even today, with supportive therapy. Now, the next point which has been very scientifically accepted is the use of high frequency HFNC in the treatment of children with moderate to severe bronchiolitis. The role of nebulized medications, be it be salbutamol, be it be saline, or be it be budesonide, none of them have stood the test of time, including adrenaline. So there have been studies which speak in favor, there have been studies which don't speak in favor. So as of now, I don't think there is a bottom line which tells us, yes, this is a drug that is useful. Over to Professor Shivananda, sir.
Regarding what?
Sir,
This bronchiolitis and nebulization, sir.
Usually, we have not found any better with using bronchodilators in case of bronchiolitis. Rather, we defer it using that rather than giving more of a oxygen and supportive, especially HFNC and supportive management and hydration.
Next question is from Kavita Lakshmi. Role of mucolytic agents like ambroxol in infants less than 6 months.
As was discussed, ambrolite is a safe medication, but it is an adjuvant medication. People are using it because there is no other choice for them to use a medication below 6 months of age. You can't use an antihistamine. You can only use a bronchodilator. To that extent, the use of ambroxol is limited. Probably it is slightly better than a placebo. Your comment, sir.
The ambroxol is a mucoactive agent. Studies have shown that it's also used, especially to be it's safe as early as 1 month of age. But you must see that they should be used appropriately with proper dosing. So benefits are there, but without that, most of the cough syrups nowadays which is available in the market, they have ambroxol, guaifenesin, and in addition the bronchodilators. So the people what I observed especially in the practice, right from the age of 1 month, people start using amboxil along with bronchodilators, along with guaifenesin. Especially guaifenesin, the combination of to give an example of that, what is that? Coferous PD or something like that. Coferous PD and all these cough syrups, which are used for newborns and 1 year, 1 month old child also, they are using that. So when the people are using that, they have to be careful because something has happened like this, or if they use overdose, they may end up in the problem. Better to use carefully, counsel carefully, and not to overuse any medications.
Our next question is again by Dr. Jalil sir. I think it has been discussed. Role of herbal medicines like turmeric, tulsi, etc. Dr. Sumita Naik madam want to know when should we consider use of levodopa.
I have not used that medication at all. The only indication I would probably use it is when the child has a very irritating cough above the age of 4 years for a short duration of time. Because it is not recommended.
Levodopamine actually is peripherally acting agent. It acts on actually activates vagal C fibers. Especially is effective reducing the cough severity and frequency of dry cough. Anyway, I'm using that the molecule is found to be effective after the age of 2 years, not below the age of 2 years. But when you give that, you should be careful about the dose. It has no adverse side effects because it is not a opiate, especially similar to non-opiate drug, and as well as is not similar to dexamethasone. So CNS side effects are less compared to that. But anyway, you have to be careful and you should not be used before the age of 2 years. Similarly, someone asked about butyramide. It's also similar to levodopa. It has a similar action, but it should be used again after the age of 3 years. And in addition to that, centrally acting depression without any CNS effects, it is having a mild bronchodilator, especially dilator effect. It's also having anti-inflammatory effect. So some of the cough syrup which nowadays which are available, they've got a combination of this the butyramide alone, or sometimes the people are nowadays. I don't know why this combination of products available. The people are the drug control is linked to the market. When I ask these people, when they come with especially the multiple combination, who permitted this? He says the central government, especially the drug control, is allowing that. For example, when I asked them why especially the citizen drops contains 1 milligram, 1 ml contains 10 milligram. And imagine 1 milligram is given inadvertently to the child sleeps off. So when they are giving that, this to be considered, especially when they are allowing these products to be marketed in the lay market or in the place where the drugs are available freely, and the controllers are not taking. Drug controllers are not especially taking seriously these aspects, whether this combination, these are available, should be permitted or not. I don't know why this combination. For example, we have a combination of this, what is that? Ambroxil, guaifenesin, bronchodilator drops. Why they're permitting to be marketed in India? And people are available, these are available, they're giving it. You don't have a bronchodilator drops. Naturally, if at all you have to give alternative these drops only. And the people are using ambroxil drops also. And especially I've seen the prescription which has been one month old child is using ambroxil drops. That's what is called mucolite drops. But anything, especially when the people are ignorant about the drug effects and the safety of these drugs, they have to be careful about when they are using these drugs. So similarly, the levo, atropine and as well as butyramate. There are newly, especially the sufficient studies of went through the literature, the usefulness of these two drugs. They're comparatively dexamethasone. This is a better drugs and having a less side effects. If you want to know more about the dexamethasone, and especially I went through the literature also, and it's the what is not been covered with dexamethasone, because that is the product that has been highlighted in the media, is a derivative of codeine, non-opiate, and then especially it acts as a central the central cough center, and is effective in dry irritated cough, and most of the time after the age of 6 years. There are a lot of limitations. Studies have shown that there's no comparatively there's no difference between placebo and this drug, and should not be used below the age of 6 years. But we are using, if at all you have to use after the age of 2 years, limit the dosing is not more than 5 milligram. And the overdose, especially the risk of overdose is there, because it's especially the teenagers, and this drug was actually available in the OTC in the US. Subsequently, there was a restriction to use this, because among the teenagers, the people using what is called DEXM abuse, and that's called as a robotroping, and they used to mix with this with other agents. They used to have what is called as a secretory serotonin syndromes. They have hallucinations, and they have, because of that only, the people start using this, and subsequently it was especially not allowed to be used as especially the OTC drug. And if at all you want to use this, only after the age of 6 years. And even though it's supposed to be safe for only adolescents, not in, but when you're giving this prescription, see that the abuse is not taken care. And coming to the, I'm just discuss about combination of the drugs which are available in our market. We have seen a combination of ammonium chloride, citric acid, diphenhydramine, and menthol. I don't want to name the brand name. The citric acid as well as the menthol is a cooling agent. Citric acid, especially there's a hypersecretory agent. One side they are giving this cooling drug, another side they are giving irritating drug. What side of a combination it is? And I think no one has looked into this combination. Why they are recommending that? And in addition to that, they are giving one diphenhydramine, which is supposed to cause drowsiness, dry mouth, especially dry mouth. It causes more irritating cough, and at the same time we are giving ammonium chloride to stimulate the cough. So this combinations are so odd, but people are using this. Coming to the honey, I'm usually fond of using honey as a cough syrup. How it works? It has a demergent effect. It acts on the cough receptor because it coats the respiratory mucous membrane. It reduces the mucus secretions. It is found to be anti-inflammatory and antimicrobial properties. Across the globe, people are using this honey as a cough suppressing agent, cough syrup. How to use this? Either you can use it in simple directly, or it's better to give it warm water. And it should not be given below the age of 1 year because of the what is called as a botulism. There's already sufficient evidence are there. There's a what is called as a the reliable studies are there, and even WHO recommending this honey as a cough syrup. So that is what you have to remember. If nothing is available, when you're counseling, tell them to give honey with hot water. That's what the even lot of literature available on the usefulness of honey as a cough syrups. And instead of giving all these drugs which are having a combination which is contrasting each other, better to use this simple drug rather than giving more of a cough medicine. And coming to that, any other questions?
Yes, sir.
Before
There are
summarizing
more
that.
questions, sir. Dr. Jalil Ahmad want to speak, sir. He has raised his hand. Sir, Jalil, sir.
Sir, thank you so much for the wonderful need of the hour, and especially during the current topic is going on. My pranams to Shivananda sir and Nagabhushana sir for highlighting this. We all following the action plan also. My message is, as Dr. Shivananda for the past 1 month or 2 weeks, I recommend only hot water, and if they convince honey, and convince the honey, sir. Regarding the ambroxol, it is a herbal product, and someone mentioned about the toxicity. And this is as a placebo we have been using. I am basically a neonatologist. Many of them that cough in a newborn is abnormal unless proved otherwise. Sometimes we may use this ambroxol because it is a herbal product. And the thanks for the Bangalore IAP, Sumita Naik and secretary. And thank you very much. Wonderful presentation, sir.
Thank you, sir. There
Dr.
is
Sunil,
sir.
there is a excellent article by Annie B. Chang,
Okay, sir.
the illustrious pulmonologist from Australia, in 2009 Pediatric Clinics of North America on cough.
Okay, sir.
I think it's a wonderful article to read. A.B. Chang, 2009 PCNA.
Okay, sir. There are some tricky questions like trustable companies to prescribe, sir.
I think it depends on your experience. You know which companies are trustworthy.
Medicine for cold and running nose in infants above 6 months.
You have two choice. One is saline nasal drops, and above 6 months, cetirizine can be used.
Okay, sir. Can we give plain salbutamol syrups in children less than 2 years with bronchi, like in bronchiolitis or in viral V's?
No, bronchiolitis is a different cup of tea where the obstruction is much below the terminal bronchi, where salbutamol does not work. But in children who have significant bronchospasm, in them it can work. Bronchiolitis, salbutamol does not work because the obstruction is below the smooth muscle area.
Dr. Vinay is asking, sir, can we expect standard treatment guidelines for cough and cold, keeping in view of the present situation, sir?
Professor Basuraj is here. I think he should be able to coordinate. And that is the need of the hour.
Yes, sir. Can we recommend mucus suckers regularly? Dr. Srinivas N wants to know, sir.
The answer is yes. And amongst us, we have Dr. Srinivas Kasi, who prescribes a mucus sucker to children under his care, all these infants, and also guides them. So this is something that all of us can adopt. And there was a request to share the slides of this presentation. I have already shared the slides with Professor Sunil Kumar, and I'm sure he should be able to share it with everyone.
Sure, sir. Sure, sir.
So one problem with using this mucus aspirators is some people overuse it and should not injure the nasal mucous membrane, and then they should not cause ulceration there.
Yes.
So in addition to that, you can also make use of this earbud as especially removing the secretions. It's quite safe rather than using the mucus suckers.
Yes, sir. Role of hydroxyzine as anti-cold medicine, sir.
The answer
usually.
Is, sir,
No.
please go ahead.
Sir, go ahead, sir.
Promethazine as well as this, usually these are the drugs which are banned for that. We better not use that because promethazine is what used to be as a Phenergan in the earlier part. That drug was abused, especially that syrup was abused in the northeast part of the country. So it causes excessive sedation and causing drowsiness and it should have side effects more because that only that was withdrawn. So better not to recommend that.
Yes, sir. Use of noscapine.
Noscapine is a cough suppressant, and now with the presence of much better cough suppressants, noscapine is a drug that is not being utilized as much as it was utilized in the past.
Role of lozenges in dry cough, sir.
Locally acting, quite sweet. It probably is better than a placebo, soothes the throat.
Yes, sir. I think we have covered most of the questions. I think
I
so.
would like to,
About-
sir, I'm Dr. Kuturesh. I would like to add a point here.
Sure, sir.
See, I've been observing all webinars since last 4 or 5 years. This is the only first webinar out of 100, only 99% present. So 10% attendance is there with this webinar. Very good combination of Bangaloreans, including professors, have given a very good topic. Ultimately, what we learned is simple water and oxygen. Two things can prevent the cough. And I think I will add a point here. When we are discharging the newborn baby, we should stop prescribing anti-cold cough, guaifenesin, and especially cough drops, everything, except vitamin D3 also. You should learn a lesson from these topics that you should stop initiating the drugs from beginning only, so we can learn a lot of things. A good message to the society people.
I am already doing it.
Thank you, sir.
Thank you, sir. Over to Shivananda, sir, for his
Anyway, the usual presentation, there's a good presentation by Dr. Nagabhushana. Hearty congratulations to him to bring out the ethical issues of that and some of the issues which are the common which are got. Ultimately, what I want to give a few messages which can be what the prescribers or pediatrician or doctors, what to do when the child presents with a cough. The simple things which they remember is most of the cough they don't need syrups. Cough is especially helps in clear the mucous membrane, mucus and as well as germs. Most coughs and colds are due to viral infections. Medicine will not cure them. What is more important is rest, warm fluid, and the most important, the patience and proper counseling. When not to give cough syrups, never below the age of 2 years. Most of the time they do overdosing, and because of the side effects, they make a sedation. And 2 to 6 years of age, only if this is needed after proper assessment and after taking the natural history of a viral cough, then you prescribe them if the child is having a persistent, incessant dry cough. And sometimes over the age of 6 years, of course, selectively can prescribe the cough syrups. What are the ingredients that should be avoided? No to codeine and phenylephrine, pseudoephedrine, because these two produce cerebral stimulant, they may produce convulsions. Chlorpheniramine causes drowsiness. Diphenhydramine causes drowsiness, better to avoid it. Promethazine is actually sedation, and especially that is may lead to a aspiration, better not to use it. And some of the drugs which have been banned, listed in India also. Codeine banned, especially basic drugs that was something available, what is called as some cold codeine preparations, Lintus codeine, that used to prescribe when you were the Vanivilas for the older children. Combination of chlorpheniramine and phenylpropionate, and for the age of less than 4 years, I told you the combination of they are the contradictory acting each other, and then unsafe syrup batches which have been frequently announced in the paper and the news media. When cough syrups may be used, it is dry cough, disturbing the sleep, and irritating cough, incessant cough. And in that situation, you can use that the recent drug levofloxacin, and after the age of 2 years. Of course, when the child is having allergic cough, better to use bronchodilators. Specific diagnosis should be made before giving prescriptions. The best thing is safer home care, warm water, honey with hot water. Sometimes steam inhalation should be given carefully. Some of these situations, especially they may burn themselves, burn the children. So better to avoid steam inhalation below the age of 2 years. And then saline nasal drops. And especially when they tell them about indoor pollution and see that the child is well hydrated. Western guidelines, most of them, the US FDA and British guidelines and the WHO warn the people using these cough syrups, especially after the age of 2 years. Only thing is, at the same time, you must know the red flags. Initially, which is saying a persistent cough, more than 3 weeks with a fever and loss of weight, refer to especially the investigate to rule out tuberculosis. When the patient is having allergic cough, incessant cough, they present with this wheezing, then examine the child properly and treat the associated bronchospasm. And if the child is saying whooping cough, that needs to be treated. But at the same time, the patient comes with the incessant sudden onset of cough, don't forget to rule out foreign body. So with this, I thank you for giving me the opportunity to chair this session. Thank you very much.
Thank you, sir. Thank you for giving crisp messages, practically useful to all the participants today. Now I request Dr. Sumita Nayak, madam, to give her closing remarks.
Thank you. It's been a wonderful evening of learning. So thank you so much, Sir Shivanand sir, and thank you so much for Dr. Nagbhushan. I think the duo, both of you, made an excellent pair to give all parts of the management and the use of cough syrup. So I think it was a totally and a wholesome session this evening. And it's heartening to see that we have had a full house. And unfortunately, there were a lot of people who did request for joining in, but I think we had reached our limit of the Zoom. So we will probably request Professor Shivanand and Professor Nagbhushan sir to have another session subsequently at another date. So thank you all very much for being with us this evening. And thank you so much for all the knowledge that both of you sirs have shared with us. And once again, thank you to all the listeners who've been with us right until the end. Thank you.
I have just a point to add. Dr. Priya Shivalli has already posted that cough article, which I can see on the chat box, 2009. So maybe that could be shared with the participants. She has done a very fast job. The PDF is there.
Sure, sir. We'll try to share it with others. And the last thing, vote of thanks on behalf of our IAP Bangalore team 2025. I thank Professor Sivanand sir, teacher of teachers, Dr. Nagbhushan sir, who have been the guiding light for today's evening session. And it was very interesting and as well as practical, sir. Thank you very much for sparing your time and knowledge with all of us. And this program was attended by a lot of seniors, starting from Dr. Kishore Baindur sir, Dr. Subbarao sir, Bala Subramanya sir, Ravi Shankar sir, Dr. Jagdish Chinnappa, Kashi sir, Madhu Pujar, Dr. Salim Khatib, Dr. Jalil Ahmad, Dr. Sudhir Bangalore, Dr. Sarala Sabapati, so many seniors. I cannot name all of them. We wholeheartedly thank you for participating in this webinar series. Most importantly, all the other participants, it was huge demand. I was getting so many messages and phone calls for increasing the number of people, which we tried, we could not do it. So probably with the permission of sirs, today's can be repeated, I think. I thank you.
Including our president-elect, ma'am, who was unable to join. She wanted to
Madam.
join and she was
Yeah,
unable.
madam. I thank our mitochondria for our IAP, Dr. Basavaraj sir, Dr. Priya madam, for being with us. And I thank all the participants who have spent their quality time with us. Thank you. Thank you very much. Good night.
Thank you. Thank you,
Thank
Dr.
you, madam. Thank you, sir. Thank you.
Thank you.
Thank you, everybody.
Thank you, sir.